know. You already know who she is.
Hi everyone. Today I am your host. My name is Emilia, if you didn't already know.
Some of you may know her from the channel.
Yes, the YouTube channel.
She is the front desk supervisor as well as the host, and I am the co-host. You'll see me sometimes. My name is CJ. I help with marketing for iDental, and I help run this entire shindig for marketing. Real quick, before today's show, as co-host, I have to tell you kind of what it's about, and I realized we forgot that. This first episode is a lot more about introductions, who we are, what the podcast is, what you can expect, and what iDental is. So we're going to start off with those introductions, then we're going to go into the Q&A portion, which for now is going to be commonly asked dental questions, and will eventually evolve into patient and viewer questions. And then we'll get to the endorsement section, and that's going to be more of where our sponsorships would be, but we're not going to have them yet. So the benefit we're giving you is that we are endorsing either a product, service, or provider. And then we go into the meat of the show, the deep dive, into the future of dentistry, changes, and things that are coming. And we end with our closing segment. So now that you know what to expect, let's get back into it. With us today is Dr. Nelson.
Good to meet you.
And he's going to be helping us with today's episode. If you guys have more questions about iDental and what the YouTube channel is, we have that listed in the description below. Otherwise, Emilia, why are we doing this?
Good question. We're doing this to inform patients so that they have knowledge for their dental appointments and why dentistry is important for your overall health and just for your well-being.
And we did this because we have been making YouTube videos for about 2 years now, and we think that we're uniquely positioned to be a thought leader in the dental space. And we acquired this room for the podcast, and we have at least a minimum of 20 podcasts planned. But we do intend on doing this for at least a year. So don't get too sick of us, guys. You died way too quick. That was fully charged when I put it up there.
We're looking to bring clarity for patients who otherwise don't understand the dental industry.
Yes, I'm glad that we're doing this. Some recent research shows the difference that over 70% of the people question their doctor. Now, they were talking about the medical field. I don't think they were talking about dentistry in particular. But people nowadays do question their doctor. They do have access to Google and various places of information, and they do have questions. So hopefully these webinars will answer some of those questions.
Perfect. And as for why we're doing this now, there's been a lot of changes in the dental industry that aren't being well recognized. We have a lot of big headlines in the news right now, and dentistry just isn't making the splash that it should. So we're trying to act as a signal boost on our part to bring a little bit more eyes to the direction of where dentistry is heading. And there's a lot of changes, even in the, what would you say, the last 2 years?
Yes.
Yeah, so we've got a lot going on. So we're going to start with the first segment. Emilia, if you could lead us.
Segment 2?
Yep, it's going to be the most common questions that patients ask.
Today we're going to be going over the most common questions that patients ask. The first one being, why do I need an appointment every 6 months if nothing hurts?
That's a really good question. People with their overall health, if they've become, for example, diabetic, they check their blood sugars. And they wouldn't question doing that, like, well, I'm taking a medicine, why do I have to check my blood sugar? Or if they're on an anticoagulant, why do I have to check my INR and check my bleeding? Well, those is pretty obvious. They have a disease process going on. The disease isn't gone, it still affects them, they're still a diabetic. They still have to be on a blood clot medicine, and that has to be monitored for their safety and their health. dental disease, they have fillings, they've had cleanings, they've had gum disease, they've had various things go on, and it continues. Just like the diabetic remains a diabetic, they continue to get cavities throughout their lifetime. And as I mentioned, those other things, those don't hurt. There are some medical issues that will scream out at you. If you sprain your ankle, it's going to scream, "Don't walk on me." But your teeth won't do that until it's pretty far gone. When you need a root canal, when you need an extraction, yes, the tooth will hurt. But prior to that, the disease will continue and you won't know it.
It's a bit like out of sight, out of mind, but it doesn't necessarily mean it's gone.
No, it's still there. It's still there. It's still continuing, and you have to maintain things in order for not to run into trouble.
Any feedback for you, Emilia?
It's just like preventative care is super important. It's like keeping up with maintenance on your car. You're gonna want to do the preventative work before anything.
You don't change your oil, you end up needing a new engine.
Right.
Exactly.
Okay. The next question is going to be, how safe are x-rays?
That's a good question that people frequently would have nowadays. Do I really need those x-rays? And then we'll talk about safety. First of all, the need. Everything that we do diagnostically is always risk versus benefit, and cost versus benefit. All that comes into play. When you go to your family physician, if you have a stomach ache, they don't send you out for an MRI because it's obviously very expensive. And instead, they'll examine you and they may do a blood panel. Again, what they're looking at is cost versus the benefit of the diagnosis and how much risk is involved. Well, drawing blood, obviously, the risk you could have a bruised arm. Now, taking dental x-rays, they say, well, is there a risk with dental x-rays? And I have to say no, because a single dental x-ray has the same amount of radiation as you receive in one day of just living here on planet Earth with the sun shining down. And if you live in your basement and say, well, I'm far away from the sun, well, the radiation from the material in your basement is going to be equally the same. It doesn't matter.
I heard concrete's pretty up there.
And it's actually up there. You're right. There's more radiation from your basement than being outside. But the point is, there's so little radiation that I'll say it almost doesn't count. Now, the x-rays that go around your head is the equivalent of 3 days of radiation. And the biggest radiation that we do is the cone beam CT. We do those for implants. We do those sometimes if it's a difficult root canal. The more difficult cases get those, and that's the equivalent of 22 days of background radiation. Then you might say, well, background radiation, is that bad? Well, everybody gets it. There's no getting away from it. At higher elevations like Denver, they have like 1.5 times more radiation than we do here, and yet their cancer rate isn't higher. Airline pilots, now they actually have a higher cancer rate because they're above the atmosphere getting that additional radiation on a continual basis. But the small amounts of dentistry is a non-factor. Then the question may be, if it's a non-factor, why do you stick a lead apron on me? The answer is you don't need it. We here at iDental, we put lead aprons on more as a courtesy in case you have that concern. But there really isn't a benefit because there's really no risk, which is a funny way to put it. But if you say, I don't want the lead apron, you don't have to wear it. We're fine without it. The State Dental Practice Act doesn't require a lead apron, nor does it encourage it. It used to, but the way I describe it is if you go back in time, depending on your age, you may remember your old single lens reflex cameras, the Minoltas, the Nikons, the Konicas, and you would take a picture and you'd have to be on a tripod because you had to have enough light and your camera couldn't shake. Now you pull out your iPhone and it can be almost dark out and you can get a decent picture. The x-rays of today have so little radiation that you don't need a lead apron. But if you want to, you can wear it. Likewise, the OBGYNs, when we have a patient that's pregnant, they require us to put 2 lead aprons on them. Now, is that necessary? Probably not. But again, risk versus benefit. There's no harm of putting a lead apron on the pregnant woman. And even though there's no risk to the fetus, yeah, the baby, it's just...
Better to play it safe.
Well, play it safe. It doesn't hurt anything, doesn't cost anything. Let's just cover up the baby and take the x-ray. But again, we only take the x-ray when it's medically necessary for a diagnosis.
Perfect. We're rolling through these pretty okay. Yeah, we can go on to the next question unless you got feedback.
I also have like a question for comparison. Would you say our phones have more radiation than a dental x-ray? Or what are your thoughts on that?
I don't think they measure it's a different type of radiation.
It's a different type.
One's ionizing radiation and the other is
radio.
RF or radio frequency radiation. So I don't know that they've ever been compared to each other as far as risk. I don't think it's a great idea to have the thing next to your brain for a long period of time. Are you going to get brain cancer from that? I doubt it. I think there's probably other factors, but...
I think there definitely is. I think there's probably more risk from the ion battery than from the radio frequency of the phone.
Yeah.
But it's pretty negligible. Those studies that have been coming around talking about how they're changing cells, radio frequency has to be extremely high to change any sort of cellular chemistry. Not that I was a biomed student.
I can tell. That's good. I love it.
Okay, let's see. The next question, why are annual x-rays necessary?
Annual x-rays are highly suggested. You want to use the word necessary. Again, because of the disease process that goes on with dental decay. A lot of times they cannot be detected visually. So with the x-ray, you can see decay between the teeth. We look at bone levels. We look at the ligaments that support the tooth to see if they're being traumatized. We look at a number of things. And on an annual basis, again, the frequency is not too high. If we wait too long, the changes can be too large and have larger problems with the tooth, such as root canal therapy.
And it's a lot can happen in those 12 months too. Like
yes.
You could have no changes for like 5 years, and then all of a sudden in 2 months, it just creeps up on you.
True.
Okay.
My next question is, why do fillings fall out?
That's an interesting question. There's a couple different reasons why fillings can fall out. The simplest thing, or I'll start with the first one, is if mechanically the filling is stressed more than what the material can hold. If you have a 4-inch thick sidewalk and a big cement truck or construction truck drove on it and it cracks, it's just the material couldn't hold the stress that it's undergoing. If we overstress the material, it can fracture the filling. That'd be one reason why it would fall out. Another reason is the recurrent decay. So if decay gets underneath the filling and the filling loses its support, it can break and fall out. The third thing is we bond the fillings to the tooth. If the bond breaks down, that can cause the filling to fall out. They actually, in the laboratory, when you bond a filling to dentin, which is the inner part of the tooth, the bond will end up in a laboratory being stronger than the bond to enamel. However, in the mouth, because it goes through thermal cycling and moisture cycling, the bond to the tooth starts out stronger than the bond to enamel, but over time it weakens. And that's one of the reasons why with dental veneers, it's important for the veneer to be bonded to enamel so that they don't come off. If the dentist over preps the veneer and bonds to the dentin, those can pop off.
kind of like a lot of those filings that we see, those nightmare filings where people shave down most of their teeth just for some veneers.
Yeah. Yes, you want to be on enamel, but those are the reasons. In line with the bonding problem, you can say the problem is inadequate retention caused by if the dentist doesn't create retentive points in the filling. So in other words, if it's tapered, it wants to come out. If it's shaped like a dovetail, like when you open a drawer and you see the dovetails that they do with the wood, if everything is dovetail, it can't come out because it's physically locked in. I prefer to both bond and have physical retention, just because I don't want to rely totally on the bonding.
Makes sense to me. It's a lot like that Japanese woodworking that interslots with no nails.
Yeah, it's beautiful. I've seen that.
Mm-hmm. By the way, Emilia, since we're not on a script, interjecting completely normal. Think like podcasts where it's banter back and forth.
Okay.
It's not unusual.
I'm glad we're not live and we can do this.
Exactly.
At first I thought we would be having no editing, and I'm like, oh, this is going to be interesting.
No, that's what he thought it was going to be at first too, but I told him we don't have to operate that way. We can
At least not yet.
Correct. But we don't have
in the future.
We don't have the equipment to do that, and no one has the training for a podcast, which, believe it or not, there is.
Yeah.
So, like, part of being a host is being able to move questions along and still be engaging, and that's hard.
Yeah.
And I'm not expecting it of her right away.
Okay.
And I'm not expecting this to be perfect.
Okay.
It doesn't have to be.
Well,
we're going to do a lot
We'll get polished over time.
Exactly. But we can move on to the next question.
Okay. What's the next question?
Kind of a weird one, but one that comes up a lot.
Oh, okay. Does insurance really save money?
That's a good question. Sometimes yes, sometimes no. Who pays for the insurance? That's a biggie. If you have an employer and your employer says, oh, we're getting dental insurance. And then, of course, you ask the question, is it coming out of my paycheck? And they say, no, it's going to be an employee benefit. Well, then it's a good thing. If you're a person, an individual person, and you get a little flyer in the mail saying you can sign up for insurance and you're paying for it, you should really look at it really closely. Just like you get those calls about the car insurance for repairs or anything like that, because the insurance company always, and I mean always, has to make money. When did you ever hear of any insurance company having a loss from paying out too many health claims? Well, when they have a hurricane in Florida and they pay out too many claims for roofs blown off or cars with hail damage, yeah, they lose money. But I've never heard of a dental insurance company losing money, ever. They usually cap it at $2,000 a year or $1,000 a year, or they have a cap on it so they know what's the maximum amount that they'll have to pay out no matter what. And then they look at how many people are making claims and they make sure that they make money. So you can save money if it's paid for by someone else. Now, that's for quote unquote insurance. Some offices have discount plans where you pay a little bit and then you get a discount. Now, that technically isn't insurance, because insurance you have to have there's an insurance commissioner in the state, and there's rules that they have to follow for insurance. And,
a lot of red tape.
Yes, and you have to have so much of a financial reserve and just lots of things, but a discount plan is something else. And then the question is, will a discount plan save me money? Well, it's not that hard. Look at how much you're going to save and how much it's going to cost. Write them both down, and if it costs you so much and you're going to save even more, well, then it'll save you money. So
they make enough, in fact, that apparently they can buy a whole practice.
Yes. Yeah. Good old dental. I want to make sure I don't disparage them by name and end up with a lawsuit.
I understand. They could just be.
Dental bought a thing called iDental, so they own like 5 dental practices right now.
Oh wow.
That's new. They just bought them.
And that's crazy, isn't it? An insurance agency owning a whole practice? Yeah.
That's insane.
We're probably going to cut this whole part out. It's fine.
Well, yeah. Yeah, because if they complain the reimbursement rates are too low, well, you own the plan, so you can just change it.
Yeah.
What do you mean you denied that claim? You own it.
Right. That's also going to be really interesting to watch.
Right. So in conclusion, make sure to look at maximums, deductibles, and copay coverage on those insurance plans.
What she said.
Yeah. Okay, next question.
This is the endorsement part of our segment. So, Doctor, do you have anything that you personally get behind?
Well, I was asked that question. I'll tell you, I personally get behind Sensodyne Rapid Relief. I'll tell you the story behind that. A lot of times sales reps will come into your office and claim how good a product is. And you listen to all their claims of research and everything else, and you kind of nod your head, and especially if they provide the lunch, you listen to what they have to tell you. My wife encouraged me to eat mandarin or oranges, clementine oranges, for the vitamin C. And after doing that for a couple months, I developed sensitivity. And I said, do you have some Sensodyne? And she said, I actually have Sensodyne Rapid Relief. And the sales rep originally at the little seminar that they provided said it can take away the sensitivity in 1 to 2 days. And in 1 day, my sensitivity was gone. So I entirely endorse Sensodyne Rapid Relief. You know, not everybody needs it, but if you need it, it works quickly. You don't have to wait a month of toothbrushing for your teeth to lose the sensitivity, just 1 or 2 days. It's a wonderful product. I also encourage people, if you don't have one, if you have difficulties with manual toothbrushes, the electric toothbrushes, especially if you lose some of your dexterity, or if you have children and they tend to be in a hurry, a lot of the electric toothbrushes have timers so that they turn it on, and you got so much time, and if it's still running, you still should keep brushing. That's a nice feature too.
I agree. Is there like a electric toothbrush brand that you know off the top of your head, you'd say?
No, most of them, virtually all of them. I mean, we're not talking
split cases.
Right. All of them work well. I don't know one that doesn't work well, but some of them, as you dive into it, there'll be features that they'll have, and you have to decide what features you want to. Again, the one that I strongly recommend is something that has a timer if you have children.
Timer makes a lot of sense to me. The integration with an app on the phone doesn't make the most sense to me, but I'm also old, so.
Well, the integration of an app on a phone, it's like, how much tech do you want on your phone, and how much are you really going to use it?
Yeah. I've heard great things about Sensodyne, though. A lot of the research I've done on various toothpastes have been pretty inconclusive. They'll be the next 99% of dentists agree, and it'll cycle out by the next business quarter. Yeah. Sensodyne has been one of those that have consistently shown up well under studies.
Well, the Rapid Relief, I can just attest that, after eating the oranges, just air on my teeth, if it's breathing in real hard or cold water, you could feel it. 1 day it was gone.
Then that's impressive.
Yeah, I'm impressed.
It
takes a lot to impress me, but I was impressed.
I'm gonna roll over the camera real quick.
Okay.
The microphones will be fine.
Active ingredient in it?
Probably. The original had like sodium nitrate or potassium nitrate. I think it was a sodium nitrate as an ingredient. Basically, the dentin on the root surface has little pores on it, and when it's exposed to acids, if you look at an electron microscope, it looks like Swiss cheese, a whole bunch of little holes everywhere. And what happens is the toothpaste plugs those holes, and when we apply an acid, it opens the holes up. So that's why when we're bonding a resin, we'll put an acid on there to open those pores up so that we can put the plastic on and bond into those holes. The purpose of the ingredients is to fill those in, and apparently whatever they put in the Rapid Relief, I have to check, does it very quickly. So.
That's nice.
And again, if you re-expose yourself to acids in your environment, it can come back. But since that one incident, I've never had to come back, so I'm very grateful.
So, I guess I'm on my way to buy some rapidly.
Yeah, I mean, you look at inexpensive toothpaste, it might be $5-6 a tube, and you look at maybe $9-10 a tube. But if it works in 1 or 2 days, you can go back to your $5 toothpaste that you like the flavor better or whatever, and then whenever you have sensitivity, just flip back again.
I think that's not discussed enough, having an actual toothpaste routine.
Yeah.
We could probably talk about that in a different episode, but some people crutch whitening toothpaste and don't realize the damage they're doing over time.
Yeah, depending on the whitening, if they just put a little bit of peroxide in the toothpaste, it's not going to whiten it a whole lot, because your toothpaste is only on your teeth for a short period of time. But they put it in so they can label it whitening. Many years ago, a cross rep was talking to me about the abrasive in toothpaste, about the quality of the abrasive versus the coarseness of the abrasive. And he used kitchen cleanser as the analogy. He said, Banyami is known to not scratch fiberglass, and yet it would typically win all the cleaning contests and Consumer Reports compared to like Comet. And Comet would scratch everything and it wouldn't clean as well. It was the quality of the abrasive that was made the difference rather than the sharpness of the little particles.
That's a really good point.
Yeah.
Okay, so we're going to go on to the next segment of the show, which is our deep dive into the future of dentistry. So, if you could enlighten us, Doctor.
The future of dentistry is bright.
As bright as everyone's smiles here.
That's right. The ability to place implants, to have computer-aided design, 3D printing. In the past, going way back in time, when someone needed a crown, it was based on metal, and it was done in a lost wax process, just like when they make jewelry, they make it out of wax, and they inject the metal in, and that's how the dental crowns were made. And then from there, it was 3D work with subtractive milling. You would have a disc made out of zirconia, and it would get milled out by a computer, and then it would get sintered, and then it would be the product. Now they're 3D printing, instead of being subtractive, it's additive. It basically makes the crown. And so things are changing. Dentures are still best being made traditional methods because the plastic is stronger. But digital is 3D printed is trying to catch up. I mean, it's catching up really fast in the crowns. The ceramic content is really increasing a lot. So that's a nice thing. So it decreases the time gap from when we do the procedure to when we can have your crown for you, which is really wonderful. Diagnostic abilities with digital x-rays have been around a long time, but the quality of the image has been increasing and increasing. Very much like your computer screens. You know, we had 640 by not 280, but whatever, the 480 by 640, I think it was, for computer screens, the resolution. And now we're up, 1200, 1600. The quality of your computer screen of what the image looks like, it doesn't look grainy. Our x-rays the same thing. The x-rays aren't grainy, they have more definition. You can diagnose better off of them, again, with less radiation. So that's good. So the materials are getting better, the ability to diagnose is getting better. Here at iDental, we try to get a lot of work done on you. People don't like going to the dentist. They don't want single tooth dentistry. In a small practice, if the practitioner isn't busy, if you have 3 fillings, you might make 3 appointments. Mainly because he wants to see that chair populated, and there's no reason. Here we realize that people's time is important to them. And if you need 3 or 4 fillings, we prefer to get all of them done in one sitting, because you have things to do. You basically hate spending time in the dental office, which I don't take personally. And if we can get it one and done, it's better for everybody.
I hear that.
How about you, Emilia? You want to book 3 appointments or just stick with 1?
I'm not coming back 3 times for like the same tooth, you know? Or like
3 different teeth and 3
different
fills?
teeth, or same 4 teeth, 1 side. I'd prefer to get it all done so that I don't have to come back. And then those the needles, those are a little scary sometimes.
Talking about the numbing agents?
Yeah. For like,
We can talk about needles. This is interesting. I've probably given about 500,000 injections in 45 years.
That's a lot.
It is. I've given a lot of injections. And just recently I did 3.5 hours of continuing education on local anesthetic, which you're going to go, well, why do you need it? Well, it's always good to brush up on things.
Pun intended.
What really stood out to me was during the lecture, all the locations, the dosage, all the stuff I knew, but they pointed out that the smaller gauge needles, which they come with a little blue cap on them, they're called a 30 gauge needle. Virtually universally in my life, I've seen dentists liking them because they assume that they hurt less because they're smaller. But on the contrary, I've actually heard research showing that they can actually say that the person can't feel the difference. As it pokes them, the gauge, the size, diameter doesn't matter. But there's research now showing that if it's small, it's much higher pressure. I tell people, think of a garden hose. If Emilia is sitting here and I spray her with a garden hose, if it's just the end, she'll be, the water will be cold and she'll yell at me. But if I have a jet nozzle on there, so it's a jet stream, it would hurt. People spray you with like a real hard, tiny opening on that same hose. It's the same hose, the same water coming up, but it's a smaller opening. It comes out as a jet and it hurts.
It's like people taking fruit and cutting them in half with a pressure washer.
Yeah. Now, in your mouth, it's the same thing. If it's a small opening, it's going to come out under higher pressure, and it's actually going to hurt more. The other thing is if you push too hard, too fast, it'll actually push the local anesthetic into the surrounding tissues instead of in the area where you want it. So not only does it hurt more, but it'll actually, you won't get as good of anesthesia if you dump it too fast. So a lot of things to consider. So when it seems like, well, why can't he just hurry up? I hate this. Because it'll hurt more and it won't work as good. So that's the answer to that.
Do you still have those studies? We could try to bring them up and post them on.
I'd have to find out. It was through Glidewell Laboratories. They had 4 separate continuing education like webinars on local anesthesia. So it was in one of the 4. I'd have to watch through to find it, but again, I found it interesting. And people do have a fear of the dentist. Speaking of just things I've learned that's kind of surprised me. 37% of the, I think it was 37, it could be wrong, there's a percentage, I wrote it down somewhere. It's in my phone. 37% of denture wearers, if you said you would give them free implants to secure their dentures, would say no.
Oh, that's crazy.
It is crazy, but the fear of going to the dentist, the fear of having a surgery, the fear of getting shot with a needle, when I had my teeth pulled, I figured that was the last time someone would ever poke me with a needle in my mouth. Whatever, but if they were told that they could get the procedure done for free, like a third of them would say no.
Nah, not me.
Yeah.
Yeah.
Free? Sign me up.
Because you got better bone density if you go with that route, right? Because it grafts right on.
Yeah, it keeps the bone density and everything. So it's, but fear of the dentist is a big thing.
And for the record, I've had 2 implants. He actually did mine, 2 bottom row, and I recovered within 2 days. I had no pain the next day, bit of tenderness, nothing that the painkillers weren't able to scrub away, but the next day it was just like it had some jaw tenderness, that's it. It was fine by after the second day. I was eating hard foods just fine. Had to wait for the cap though.
Yeah, yeah, you have to wait 3 months, 3 to 6 months for bone to attach to the implant. Usually we figure about 3 months nowadays. They used to tell us 6 months for the upper and 3 months for the lower, but the improved coating on the implants, they said you can do the upper in 3 months and the lower in 3 months.
See, it's kind of the updates that are useful to get out there. We still have, I'm going to say, about 15 minutes. If you got something you want to jump on, Doctor.
I had a question.
Sure.
Kind of jumping back to like the X-rays and advancing technology.
Sure.
Have you seen like the AI
Okay, that's a good question.
diagnosis?
Yes, that's a good question. There is AI diagnosis of X-rays. I've seen pictures of them. I haven't personally worked with them, where it'll look at the pixels and it'll determine the shades of gray in the pixels and diagnose the decay, diagnose different things for you. I think that can be a useful adjunct.
It should only be adjunct, in my opinion.
Right, it should only be adjunct, and here's a bizarre thing. Frequently, but not always, you can sometimes detect decay in the mouth by looking with loops and a light before the X-ray will pick it up. There's a phenomena where if it's decay between the teeth and premolars and molars, where the edges of the tooth, called the marginal ridge, will become more opaque when there's decay happening, and you'll pick that up before you can see it on the X-ray. So the other phenomena that they had with X-rays, now again, I love the X-ray technology of today, but even prior to me becoming a dentist, I became a dentist in 1980, I graduated. In the 1960s, the film speed of the X-rays were so slow that the resolution was so high that we can't really reach that same level today, which is bizarre. People that were into photography may have heard a song by Paul Simon called Kodachrome. Kodachrome was a slide film that had a ASA speed of 25. It was extremely slow, but it took these beautiful, magnificent pictures. And what happened with the dental X-rays in the 60s was what you see was what you got, and later on, when you saw the decay, there would always be more decay there than what you see on the image. So the X-ray would point out the image of decay, but when you got in there to clean it out, there would always be a little bit more. So we trust our X-rays, but we also have to trust our clinical experience.
Oh, so we still need doctors, is what you're saying.
Yes, we do. The same thing holds true with cone beam CTs and digital implant planning and all that. It's wonderful. It's wonderful that we have that. But even though you can kind of predict the bone morphology, what the bone looks like, and the bone density through all this technology, your skill as a surgeon, when you get in there, it doesn't always look exactly like what it looked like in the image. The bone quality will rarely be better, but frequently it'll be worse, and you're going to have to adjust for that when you're doing your surgeries. And so clinical experience still trumps technology, which...
Checkmate, robots.
Yeah, I mean, it's helpful. I mean, every practitioner would like a non-critical eye looking over their shoulder, pointing things out in case they miss something. But on the other hand, it might point stuff out and go, checked in the mouth, that's really not decay, it's what we call cervical burnout. Okay, for those who aren't well informed, a cervical burnout is when the tooth transitions from enamel on the outside to the root surface, or dentin. As it does that, sometimes there'll be a part of the image where it almost appears like decay, but it's really not. It's the change of density, and it's called cervical burnout. And if you're aware of what it is, I mean, you could teach AI that, well, what cervical burnout looks like, but you would have to kind of know that the subtle differences and be able to suggest things differently. But
yeah, we're not quite there.
No. But those are good questions.
Yeah, excellent.
AI to be my dentist.
You want an AI dentist?
No, I don't.
I don't think anyone does.
It's odd. I think it's crazy how it can diagnose or like.
Well, technically, a dental hygienist can't diagnose. They're supposed to, if they see what they think is decay, they can say, doctor, it appears, and that's the word that lawyers like, it appears that there's decay on, let's say, the occlusal of number 3. Because legally, a hygienist can't diagnose. But if they say it appears, they're saying it looks like it to me, but you're the doctor, you have to decide. I assume we're going to do the same thing with AI. AI will be like, it appears, and then it'll go through the whole works, and then you'll go through and you'll either agree or disagree, you know. And I'm sure the big thing is insurance companies will want that, or they'll look at it and say, okay, is it valid or isn't it? And then the other problem is not all images are diagnostic enough for it to always be valid. So like if they're taking bite wing x-rays and if it's a perfect bite wing and the teeth don't have any overlap, you can see right in between there. Well, fine, but for you people who love physics, there's a phenomenon. I want everyone to, it's not just aperture diffraction, but if you think about the x-ray image and the distance between the tooth, the image plate and the radiation source is very, very short. If something is far away, all the things are going parallel. So in other words, if the source of the x-ray was at an infinite distance, we could put a sensor plate in there and we could get all the x-rays to look perfect. But we don't, because it's coming like this, whatever is over here won't necessarily be as good as what's exactly right here. So that's why they take multiple images, because you're not getting that. Now, you say, well, what about the cone beam and what about the panoramics? Well, that goes around, so that kind of solves that problem. However, it solves that problem on an average. What they do when they design the software that makes the thing spin around and makes it image, they try to calculate what does the normal dental arch look like. So if your mouth is real narrow, the images won't be as good. If your mouth is real wide, it won't be as good. It's looking for that average as it's trying to get that image going around. It'd be like if I focused a camera at 4 feet and I took your picture. Well, if you're 4 feet away, you're in focus. But if I took it and CJ's over there, well, he's not in focus because he's not in that zone or something.
Yeah.
So it's looking for that zone, and that's a problem for AI too. I mean, it's and things aren't perfect. It might be confused until it learns. But even then, it'll be just advisory.
I think it should always remain an advisory, just because, as impartial as AI can be, you know, that they base their whole scan upon hundreds of thousands to possibly millions of different X-rays of that same type, and that's how they're able to spot aberrations. But it's a problem for me to know where that technology is coming from. If that technology is coming from a biased source, they may have some back end where they don't wish their tech to look compromised in any sort of way, and that would lead to a misdiagnosis just based off of failure on the back end that they don't want to admit to. And it should never be on the tech side. It should be on the doctor side to say what something is definitively because of that.
Good point. Agreed.
And I think that wraps us up for the bulk of our deep dive, but we are in closing. So, in conclusion, Emilia.
Alright, thank you guys so much for listening. If you have any questions, where does this go? Is there going to be like a comment section?
Yep.
Okay.
So we're going to have a page on the website for questions for our viewers or patients to submit to that we're going to answer in the Q&A segment of the show. The Q&A is after the introduction of each episode. So that's how it's all going to break down. And then we move into the Q&A and then into the deep dive and, well, of course, our sponsorship in between.
So they'll leave their comments on our website.
Yep, they can post them on YouTube as well. It's just we're probably going to respond to those with a message and not a dedicated If it's a good enough thing, we might do that.
Can you do me a favor, take a picture of us?
Yeah, 100%. I needed to anyways. Okay, and then I'll get one for myself because I need promo material. Smell big? And yeah, mine doesn't have a little shutter sound. Same idea. Perfect. All right, that wraps us up about 5 minutes early.
How hard is it? The editing work you do, is it a little difficult?
For the YouTube videos, it's far harder than this. For that, I have to cut everything out, any possible mistakes, any weird sounds. I have to color match and audio match, make sure everything is synced. And then I make jump cuts through everything that we don't want anyone to hear or just a mistake or something. If there is a problem with lighting or glare, I have to edit that out. Overall, it takes at minimum as long as it took to record.
Maximum,
and it's
maximum would be like 8 times as much.
Correct. I've edited for 6 hours before on a video with just me and her, and all it was 40 minutes of footage.
Oh, jeez.
So an hour long, and I'll take you guys as mics.
Well,
an hour long is going to not be as hard on a podcast because there's so much less. I'm not putting graphics up. I'm not putting all this other stuff to keep people entertained. The idea of a podcast is that the information is good enough alone, and everyone knows that it's going to be long form.